Good afternoon, ladies and gentlemen. I'd like to thank the organizing committee for giving us the opportunity to present our work today entitled Utilization of Pre-op Vein Mapping in Patients Undergoing Infrainguinal Bypass is associated with increased use of venous conduit. We have no disclosures. So autologous vein has been shown to have the best patency rate when compared to other conduits for infrainguinal bypass. Pre-op vein mapping with duplex ultrasound has become the standard for determining the presence and suitability of autologous vein as a bypass conduit. In addition, pre-op vein mapping has been shown to reduce unnecessary surgical exploration and postoperative surgical site infection. So the aim of our study is to determine, using a real-world registry of lower extremity infrainguinal bypass, first, the utilization rate of pre-op vein mapping prior to bypass, and second, whether pre-op vein mapping was associated with increased use of venous conduit. To do that, we used a statewide vascular surgery quality registry, the Blue Cross Blue Shield of Michigan Cardiovascular Consortium, or the BMC-scored VIC, and we queried it for all infrainguinal bypasses performed between 2012 and 2020. We used the VQI infrainguinal bypass module, and we queried it for descriptive analysis of pre-op vein map use. Preoperative and intraoperative variables were analyzed, and postoperative outcomes were correlated with pre-op vein map use using univariate analysis. So a total of around 7,500 patients underwent infrainguinal bypasses after excluding trauma patients, patients who presented with acute limb ischemia, and patients who had previous infrainguinal bypass. We ended up with around 5,500 patients. Average age was 67 years. Most of the cohort were male and white. As you can see, more than half of the patients did not undergo pre-op vein mapping prior to their infrainguinal bypass. This table compares the baseline characteristics and some of the comorbidities between patients who had pre-op vein mapping and those who did not. As you can see, patients who had pre-op vein mapping were more likely to be white, had commercial insurance, had higher BMI, and were more likely to be diabetic. In contrast, patients who did not undergo pre-op vein mapping tended to be current smokers and have a history of COPD. Patients who underwent pre-op vein mapping tended to present with lower ABIs and more advanced peripheral artery disease with rest pain and tissue loss. On the other hand, patients who did not undergo pre-op vein mapping tended to present more with claudication. Around 70% of patients who underwent pre-op vein mapping ended up using a venous conduit for their infrainguinal bypass. In contrast, around 70% of patients who did not undergo pre-op vein mapping ended up using a prosthetic graft for their infrainguinal bypass. When looking at patients who had a venous conduit and comparing their intraoperative variables, patients who did not undergo pre-op vein mapping tended to have higher estimated blood loss, were less likely to undergo post-reconstruction imaging, and if imaging was performed, was less likely to be reported as normal. When looking at outcomes, patients who did not undergo pre-op vein mapping tended to stay longer in the hospital and required more transfusion at 30 days. No significant difference was seen when looking at other outcomes such as 30-day amputation, readmission, or death. No significant difference was seen when looking at other outcomes such as 30-day readmission for wound infection, graft infection, revision, 30-day or 1-year patency. This table compares the BMC-squared VIC, or quote-unquote the real-world scenario, and the VQI, or the national, which is considered the national benchmark. Only 45% of physicians in the BMC-squared did pre-op vein mapping before their infrainguinal bypass versus around 70% in the VQI. When looking at all patients, only 46% of patients in the BMC-squared had a venous conduit for the infrainguinal bypass versus around 70% in the VQI. However, in both cases, if a pre-op vein mapping was performed, a venous conduit was used around 70% of the time. So in summary, in the study, most patients did not undergo pre-op vein mapping before their infrainguinal bypass. Patients who underwent pre-op vein mapping were more than twice as likely to have a venous conduit used for their bypass. Patients who underwent vein bypass post-reconstruction imaging to establish technical adequacy was performed more frequently in patients who underwent pre-op vein mapping and was more likely to be reported as normal. To conclude, when compared to national benchmarks, or the VQI, surgeons performing infrainguinal bypass in the BMC-squared utilized both pre-op vein mapping and autologous vein at a lower rate for infrainguinal bypass. Pre-op vein mapping may be a marker for physicians committed to best practices for infrainguinal bypass. Thank you. Happy to take any questions.
Great, thank you. Are you able to tell whether the vein mapping is done like officially in a vascular lab or just by the surgeon in the operating room? Is there a difference?
Is there a difference between the two?
No, can you tell in the VQI?
No.
Do you think there's a difference?
Maybe. I'm not sure.
There's been a lot of work in this space in the AV access field, but really nothing that I've seen in infrainguinal bypass, so it might be worth sort of exploring.
I always enjoy studies that confirm my pre-existing biases. And why would you not want to go into the operating room with as much information as possible to know whether there's a bifid vein or is a segment of phlebitis? You don't go chasing some branch. And so it's a nice demonstration of that. Just one question. Did it have any impact on outcomes, on patency? Or?
So in the BMC squared, we only had 30-day and 1-year patency. We did not have longer follow-up. So so no significant difference was seen at 30-day and 1 year, but probably if we have longer follow-up, we might have seen a difference.
Thank you.
Thank you.